I am Dr. Dennis Goodman. I'm a clinical professor here at NYU. I'm Director of Integrative Medicine, and I'm part of the preventative medicine team at NYU. And I am very proud of our lecture series, and it's mainly myself and Ania, and we have Julia, and between the three of us, we've put on many programs. The next ones to know about, and I'll try to always think of great topics and things you'd be interested in. So coming up on April 24th is oral hygiene and your overall heart health. Big issue, big topic, and that's going to be April 24th. And then May 22nd, which will be the last one we do before we take our summer break, is Alzheimer's disease and cardiovascular disease. And we want to update people with the latest information and what can you do to try to prevent this horrible disease. Here's information about our series. If you want to get in touch with us, our website is there for you. You can join our email, and all you got to do is sign up in the front there, and Ania will take your information and we'll keep you up to date with everything that we're doing. And you could also follow us on Twitter, so we're up to date with social media. So some of the topics that we've done, I always put the slide up. You can see, I'm not going to read them all because I don't want to waste time, but you can see we've really covered so many great topics: pre-diabetes, weight, natural options for heart health, sleep, hormone therapy for men and women, stress management, nutrition, blood pressure, osteoporosis, the microbiome. And today we are going to do one of the most important topics that I can possibly imagine. And I hate to say this because this is being recorded for people to listen to. I just hope there are going to be millions of people listening on YouTube, because isn't it ironic that the most important thing of all the risk factors for cardiovascular disease that you can do is to stop smoking if you smoke. And this is by far the worst turnout we've ever had. And I actually asked Donna, and she said, well, it's to be expected. And I'm going to let her tell you why that is. Why it is so hard to get people to come out and listen to this topic. But I want to just say that I was on my way to work today, and can you believe it, I see this sign. And if you look carefully, you can see that this is actually one of those newsstands. And this is on the back side of the newsstand, and on the other side, there's this fellow selling cigarettes. And this is this dichotomy that we have in this country, which is absolutely insane. We spend money on cancer research, lung cancer research, and we spend money on trying to tell people not to smoke, and we sell the cigarettes because there's a huge lobby that goes on to make sure that we can keep cigarettes around. I don't have to tell you, and that's why we have Donna here, but I am absolutely heartbroken as a cardiologist that this habit is causing such terrible illness, and the government does not stop it. And I understand when people are addicted, it's a big challenge to stop. But why do we allow our children to even get started in the first place? So Donna's going to address some of these issues. Here's the sign. Look at the number of people dying every day. 500,000 people per year dying of lung cancer related to cigarette smoking. So I have a patient that came to see me today. And I haven't had a patient like this for a long time. 40-something years old. He's 44 years old. And he says, I'm addicted to cigarettes. And I've tried everything. And I don't know how to stop. And I know it's bad for me. And I don't know what to do. And so I'm busy working him up right now for underlying cardiovascular disease. We got to look for plaque in his arteries and plaque in his neck. And he's going to check his lungs. But he knows that he is doing himself damage. And then he pulled out this picture. And he said in 1999 in England, they had a cigarette company called Death Cigarettes. And can you believe that they actually, I think, lasted about 9 years. But people were buying this pack of cigarettes And I find it absolutely, I'm sorry to have to keep harping on this, but how is it that people, when they know how bad it is for you, even start? And Donna, I'm throwing all this out because I hope you're going to address some of it. This was in Annals of Internal Medicine this week, the association of e-cigarette use with smoking cessation among smokers. In other words, and I'm not going to tell you what this shows because I don't want to steal any thunder from Donna, but can you go to e-cigarettes, and do you think that'll help you quit smoking? So let me introduce Donna, who's our speaker. I'm so grateful that she came. This, I would easily say, is one of the most important topics that I've done. Donna is an associate professor here. She's part of the public health department, and she is actually a primary care physician. She's passionate, and I hope she'll tell her story. Donna, why don't you tell us how you got into this before you actually start your talk? She served as director of the Tobacco Control Program at the New York City Department of Health. She's the founder and director of NYU Langone's Tobacco Cessation Program at Perlmutter Cancer Center. She's active in several nicotine addiction studies that are funded by the National Cancer Institute. She's actually doing community health work in Vietnam, and she works with lung cancer screening programs. Donna, thank you for coming. We are very, very grateful that you're here, and we're privileged to have you.
Let's see.
Just go to the next.
Oops. Oh.
Can we turn the lights down a little bit? Because actually...
I think it was okay, actually.
Is it?
Yeah.
Oh, okay.
Not too dark. Okay.
Not too
yeah.
dark. We can go with. Good.
Yeah. So I was an internist, a long time ago, and I decided, got my master's in public health while I was practicing medicine at Mount Sinai in the women's health program, and I got some brochure on my desk that said, get your public health degree at Columbia through the executive program, and I did it, and then it changed my life. I decided I wanted to do population health, and so I went, got my master's, and left, and became the first director, actually, of the tobacco control program at the City Health Department. It was a long time ago, in 1999, when the Master Settlement Agreement happened, and the states got all that money from the tobacco industry. I fell in love with this field because, as we just heard, nothing could be more important than helping people quit and preventing kids from starting. And so I remember calling my husband at my first tobacco control conference and saying, "Oh my God, I found my people. Like, this is really incredible work that's happening." And so the thing about me was I'm not really, it didn't feel comfortable being at the City Health Department, since I kind of missed the academic environment, then went back to academia, where I've been doing research and trying to help people quit, and more recently working at the Cancer Center, clinically helping people quit. And what's striking to me is, what's been nice for me is I was getting to spend 45 minutes with a patient. Your typical internist has 7 to 10 minutes to spend with you. And so it's really hard for them to get into this deeply. So they're more likely to really turn you off, actually, with this conversation. Because they're basically going to say, "You need to quit. Why haven't you quit yet? Here's a prescription for Chantix. Goodbye. See you in 3 months." Not exactly something that really motivates, actually, or even shows that there's an understanding of how incredibly difficult this is. And just coincidentally, I saw a patient, 38-year-old, yesterday, who had been abstinent had smoked 2 packs a day since he's 16, got married, 2 kids. His wife said, enough. He quit 7 months ago, and he was in to see me because he was going crazy. He actually felt he had been okay and felt such incredible cravings. I don't know that they're nicotine cravings necessarily. I think what happened was his life got a lot more stressful with a new baby, and then he just started his own company. And the things that used to trigger his smoking are happening again in his life to in a large degree, intensely. So it's the behavior. It's the, I remember that smoking was the thing that made me feel better when I felt like this. And so, we talked about, should he go, he was like, should I start on nicotine gum, or should I try the e-cigarette? And I said to him, you're extremely addicted. You were a very addicted smoker, and I'm a little nervous about you going back on nicotine because it could actually lead to you starting smoking again. At the same time, I know people who've been using nicotine gum for 20 years. So it's not the nicotine that's harmful. It's the other 7,000 chemicals and cancer-causing agents that are released when you burn tobacco. So it's not doing. Actually, one of my closest friends, after dinner, every time we go out to dinner, she pops in, a nicotine gum. If it keeps her off cigarettes, that's great. So this is, what I told, the patient I saw yesterday, this young man. I said to him, quitting is a journey. It takes time. It's a process. And it's like any behavior change. If you've ever gone on a diet, how painful is that when you walk by every single cupcake store there is now in the city? Or, when you crave sugar or you crave this and that and you have to fight it and fight it and fight it. And it's a process. And sometimes you slip, just like you might slip and smoke a cigarette. But remembering, why you're quitting and what it means to you and thinking about the future of the people that are meaningful to you, or that you're just sick and tired of being a smoker. Reminding yourself of those reasons can help people really get back on track. It's not easy to be a smoker, particularly in New York City, because it is a stigmatized behavior in New York and elsewhere in the United States, not everywhere. So that's why we don't see a lot of people in the audience in these talks, actually. So thank you for coming. I really appreciate that you're out here today to learn something. So I have the sort of privilege and opportunity to spend a lot of time with my patients trying to help them quit and really taking them through these questions of, tell me about your day. How soon do you smoke when you wake up? What's the next cigarette? What are you doing? What are you not? And I'm going to show you a track pack I make them fill out where they track their behavior over a period of several days. It's hard to get people to really do it for a week. But I have some patients who do it for months and months and months, especially people who want to reduce to quit, which I don't recommend because it's very hard to do. But some people want to do that. So, really going into details about this behavior. The good news is you don't necessarily need someone like me anymore. You can go on some great websites, and I'll show them on the slides. There's text messaging programs. There's a lot more support than when I started working in this area now. And even some of these websites, like the New York City Department of Health's website, this Become an X, the smokefree.gov website, they have communities. You can actually get text messages from them, join an online community, have a text and have a coach call you. So there is real support out there, actually. Because just to say, I'm a physician, so I can talk about docs this way. Physicians are not trained in behavior change. And so it's important to talk to your doctor about it, ask them about it. That's who's going to give you a prescription if you need one. But there are other ways to get help, if you want to quit. And we'll talk about that a little bit. And I don't have to tell you, but this was the 2012 Surgeon General's report. Every few years, the Surgeon General comes out with a new report, and the red text are the new organs that we now have definitive evidence are impacted negatively by smoking. So the number of organs grows, and basically, as I like to say, no organ is left untouched by this product. So obviously lots of reasons to quit. The good news is that, now is the time. Like the sooner you quit, the more benefit you gain. And a lot of smokers say to me, well, what's the point? I've been smoking for 40 years. What the point is that you'll immediately start breathing better. Your circulation will improve immediately. I've seen some pictures of PET scans of people who smoke, and literally their vascular system shuts down, and they get vasospasm as you're smoking. So you stop smoking, your circulation gets better, your breathing gets better. Within a year, your risk of having a heart attack is in half. So you won't smell. You'll save money. You won't have to walk out of every event to get a smoke, when you're sort of supposed to be at the party or at whatever you're supposed to be doing. You won't have to make excuses and not smoke in front of your grandkids. It's tough being a smoker. And, certainly when people get to a certain age, I usually see people who've waited a long time. And unlike the 38-year-old who really just wanted to go back to smoking so badly, but I really think he's not going to. We talked a lot about that. But the older patients I see are really, if I challenge them and say, do you even like smoking anymore? what do you like about it? And, they actually start to talk about what they don't like about it. Because at some point in someone's life, they sort of feel like, I really am so done with this. I don't know that I can quit, but I feel so done with this behavior. And that's when the real change can happen, honestly. Part of the reason this young man was stressed out about this was he didn't quit because he wanted to. He quit because his wife insisted. And so I believe very much in intrinsic motivation. I give him a lot of credit. But it's up to you, to make that decision. So this is what I was just talking about. The sort of circulation improves, lung function increases within 2 weeks to 3 months, on and on and on. I'm not going to spend time on that. One of the things I think people don't understand is, one of my, everybody, I think people are a little more educated about this as an addiction. I think that was one of the problems is that, we talk about heroin and cocaine and whatever, but people didn't see nicotine as an addiction. They thought people who smoked were bad people, what's wrong with them? They know it's bad for you. That's changed a lot, not enough, because I think it's important to really acknowledge that this is an addiction. But it's not just a nicotine addiction. It's also a behavioral dependence. And the reason why I want to point that out is if it was just a nicotine problem, everybody we gave nicotine replacement therapy to, or Chantix, or whatever we're giving them, would be cured. It's like insulin. You take insulin, your sugar goes down. But the quit rates with these drugs are not ideal. Like they're 25 to 30% maybe at 1 year, and if you use it the way you're supposed to, which most people don't, and I'll talk about that. But it's this behavioral thing. That's why it's so important to track your behavior. That's why I go through in detail. Tell me what it's like, a day in your life of smoking. I'm not talking about cravings. I want to know what you're doing, what you're thinking, what you're feeling when you're smoking each cigarette. And when you start to tease that apart, you start to define the behavioral dependence part. The reason why I like people to track also is that sometimes they'll realize, gee, I woke up in the morning, and if I ask them, how many cigarettes do you smoke in the morning, like when you first get up? 3 or 4. I said, well, after the second one, you probably don't need more nicotine. You probably tapped out. But it's this panic. Like you wake up in the morning, you haven't smoked for 8 hours, and you're in withdrawal. And you're just like smoking in a state of panic, kind of. Also, you're having your coffee, so it's kind of nice. But why do you need 3 cigarettes? You'd only need 1 to get back up the level. But there's kind of this behavioral process that has happened over years. I tell people, like, if you still need your coffee, go to Starbucks to have. Although I hate Starbucks. I don't go to Starbucks. Whatever coffee place you go to. You can't smoke anywhere in New York City inside. So go inside. Go, buy a paper, sit inside a coffee shop, have a cup of coffee, and don't smoke. And start to practice that every single day until you no longer need a cigarette with your coffee. Because most smokers have learned this behavior over years and years and years. So how do you unlearn it? It's about trial and error, coming up with strategies, trying and error, trial and error. Smokers don't realize they're actually using strategies. So I try to make them aware, like, wow. They'll come to me and say, gee, I was able to reduce by 3 cigarettes from 20 over the past 2 weeks. Well, what happened? What did you do differently? And there's very little insight. So I'm asking you to sort of think about that. I say to my patients, like, really think about it, because you must have used some strategy to not smoke those 3 cigarettes. So smokers oftentimes don't realize, first of all, they're thinking about it all the time. When's my next smoke? I don't want to smoke. It's like this constant thing in your head. But that, you can try out things. I'm not going to go out for my lunch cigarette. I'm going to have lunch and let's see how I feel. What's a worst case scenario? So this behavioral piece is so important. Again, because doctors aren't really trained to do behavior change, they're much more comfortable writing a prescription and forgetting about this other piece. It's so important, which is why, but as I said, there are resources for you outside your doctor's office to get that behavioral component that you need, the behavioral counseling, behavior change therapy. This is withdrawal symptoms. I really urge people who smoke kind of more than 5 cigarettes a day to use some kind of medication when they quit. The evidence showed that combination of medicine and counseling is the best way to go. Many smokers these days are people who actually have mental illness or depression or other issues, substance abuse problems. And sometimes it's hard to tell whether it's your psychiatric symptoms or their withdrawal symptoms. But I'm sure those of you who smoke in this room are familiar with these situations, because there's no smoker who's ever not been in a situation where you couldn't smoke. One of the things that's interesting to me is, you talk to like a grandma. I've had many grandmas in my office who said, it's funny, when I spend the weekend with my son and his kids, I don't smoke all weekend because I won't smoke around the kids. The minute I get home, I smoke a cigarette. So you've gone 2 days without even thinking about a cigarette because you're having so much fun with your kids and you don't want to smoke in front of them. You don't want to be the grandma who smokes. But that's very typical, but she knows she can smoke when she gets home. So it's not anxiety provoking. Quitting, I think it's important to acknowledge, as I do to my patients, it can be quite anxiety producing to change any behavior. But to think about life without cigarettes is incredibly anxiety producing for a lot of people, which is why they haven't done it. Because when I was a kid growing up, I learned coping behaviors without smoking. But when a smoker starts smoking at age 15, 16, that is their coping strategy. And that's why this 38-year-old young man didn't know what to do. He couldn't even imagine what to do with all this stress except to smoke a cigarette. Because his whole life, that was what he did. So he's young. So I said, I literally prescribed spinning class 5 days a week. And I don't know if any of you have done this cycling program, but you walk out of there and you feel like you've just been on drugs. The National Institute of Drug Abuse actually is doing studies on exercise and addiction, and showing that there's a real positive impact on people who exercise intensely are more likely to be able to get off addictive drugs. So again, he was 40, he's 38, he's still young, and he had been a spinner. And I said to him, "What are you waiting for? You are really intensely into this thing. Now you need to get really intensely into this thing." And he texted me yesterday. It's like, I'm already signed up. So anyway, medication takes the edge off. I said to people, why suffer? It's because you have to deal with the behavioral problem. Why have to deal with withdrawal too? So the medication is really to help you deal with the withdrawal, so you have one thing kind of put aside. Doesn't mean you're not going to have some cravings. You might, because again of that mental association. But it's, I've had patients say to me, actually the funniest patients were my homeless patients. I did a study at the homeless shelter on 3rd Street, and they said to me, all of these men were on methadone, by the way, which is a harm reduction for hard drugs. And I said, you should take nicotine replacement therapy. And why would I want to stay on the drug, that I'm addicted to? I said, well, what do you think methadone is? It's harm reduction. I'm offering you harm reduction, the safe part of the cigarette, the nicotine. But it was interesting that insight wasn't there. So I do get some resistance. I don't want to be addicted to nicotine. Well, the best way to get off nicotine is to get rid of the cigarette version of it, the dangerous delivery system, and use a safer delivery system. And I will say this is an important slide because this box tells the truth. Most people they say, oh, you stop for 2 days, and you'll be fine. Get off my medication. And it can take a month. It can take 2 months sometimes for withdrawal symptoms to really dissipate. We did a study actually where we mapped it. It was pretty consistent and interesting to see that. So what's the recommendation for medication? A minimum of 3 months. If you're using varenicline, it's approved now for maintenance for another 3 months. So I prescribe 6 months. I really want my patients to stay on these medications for 6 months. Sometimes insurance, financial issues don't allow it. But, and that's my preference, but at a minimum of 3 months. People never use the medications that long, unfortunately. My patients do, because I tell them. They never heard that from their doctor. Oh, just take we had, take it for 2 weeks, or take it. You can't, because the point of it is to keep the withdrawal at bay. If you stop it after 2 weeks, you're just going to put yourself into withdrawal again. Don't be worried about nicotine replacement therapy. leading to addiction to that. Only about 5% of people who use the short-acting, the gum, the lozenge, the inhaler, become addicted. It's really rare, and the patch is a delivery system that does not lead to addiction. So when you stop the patch, you're done. You won't suddenly fall into withdrawal. But stay on, if you're going to bother taking the medication, stay on it for at least 3 months. So this is my track pack. It's not, it's really easy to do. And the website sometimes, these websites also have places like, where you can track your behavior too. And this is my favorite one. There are lots of versions of this, but I love it because it has that need column. Because that really helps smokers, especially smokers who smoke 20 or more a day, to start to realize, I haven't put all the data in here. So it's your first cigarette of the day. You write the time of day. Was it strong, medium, or low? Your craving for it, your need. What your mood was. It could be bored, right? Boredom is a big trigger for smoking. Happy, sad, indifferent. And what were you doing? And this is the way you map out identifying triggers, leads to a plan of action. This leads to a quit plan. But the neat thing, a lot of times people will see they have L, light, in all over the place, like that fourth cigarette in the morning, realizing a lot of insight into like, gee, 5 of these 20 cigarettes I actually didn't even have a craving for. And so that's a very helpful thing to do. Even if, sometimes I get pushback, I know when I smoke. And I hang tough. Like, no, I'm sorry. I don't even remember what I ate 5 minutes ago, okay? There's no way that you don't have cigarettes that you just don't realize you had, okay, during the day. You have to track it to understand your behavior. The first step to quitting is really defining your smoking patterns and what it is that makes you smoke. The easiest ones to change are the activity ones. So I gave you an example. You're smoking cigarettes, you do something else, you go somewhere, with your coffee, you go somewhere else, just switch to tea. The exchanging activities is sort of easier. Mood can be tough. Get a friend, get a pal. Again, when you go on, I'm really urging you to check out one of these websites because it gives you lots of tips and lots of ideas about what you can do instead of smoking. So that's my track pack. How you handle places and events. A patient of mine, actually, I just saw another patient Monday who we've been meeting actually weekly for over a month because she really is nervous about quitting, and she has to make Passover dinner Friday night for 30 people. And she's like, patients always come in afraid I'm going to tell them they have to quit today. Like, my doctor sent me to quit. Do I have to quit? No. So I said to her, don't try to quit this week. It's okay. But there's always going to be another event, another thing. Cooking dinner for 30 people is quite a stressful, thing. So I said to it's okay. No problem. Let's put the plan into action, even at the week. Passover is a week, like the week after Passover. And she wants to, but one of the things I did say to her, she's smoking in her apartment. Her husband stopped smoking like 7 years ago because he had lung cancer, okay? And she's smoking in her apartment. Now, I kind of, I consider myself pretty sympathetic and empathetic, obviously, towards folks with this addiction. But I said to her, like, one of the things is creating dissonance. How does that line up with your values, actually? Like, does smoking in your home, where your husband's smoking, breathing in the smoke, he had lung cancer before, how does that make you feel about yourself, actually? And she said, terrible. I feel horrible about it, actually. And he kind of, sometimes he gets annoyed at me. I said to her, the one thing, she's really is still not ready to quit. She's going to start to try and decrease 2 cigarettes a week, and I'm going to be giving her Nicotrol inhaler to replace each cigarette with nicotine. It's a complicated process. I don't like to do it with everybody, but she insisted. I said to her, this plan only goes into action if you stop smoking in the house. It's spring. It's getting warmer. Go outside, in your bathrobe, and smoke a cigarette, but do not smoke in your house. By definition, that will reduce the number of cigarettes you're smoking per day. it will start to, again, change that activity, change the activity. Smoking is such an integral part of a smoker's life. If you don't change it up, you will not be able to quit. You have to change your life. It sounds very dramatic, but it's not really if you plan it out. What can you do differently? I cannot smoke in my house. Very few people who live with a non-smoker will smoke in their house. Most people with children won't. Or they'll pick a bathroom and open the window, but that smoke is getting into your home. So, these are just some of plans. I really, again, using the websites, it helps you document, but what are your reasons for quitting? My top 3 triggers. What will I do to manage these triggers? Start to set up a plan. Sorry, someone want to take a picture of this? I don't know if the slides are available, but writing down your reasons, putting them on the we all put stuff on our refrigerator to remind us of stuff, right? I have one saying, buy a pound of mushrooms tomorrow, and, putting some, every day when you open up your refrigerator, get your coffee out. To make your coffee, you're going to see, these are my reasons for quitting. So these are, I don't have a watch. Do you know what time it is? Oh, okay. Well, I really want to get questions in. So these are 7 FDA-approved medications. I don't use the spray, but I use a lot of the inhaler, which is... Sorry?
And turn the light off on the screen.
Oh.
It's easier to see the light off.
This is the inhaler. I have no control of the light, so she's going to take care of it.
She's going to do it. She's right on it.
Anya's right on it.
I'm working on it.
Okay. I don't like people to fall asleep, so I don't like to get too dark. But the gum, the patch, there's the inhaler. I have pictures of bupropion, which is Wellbutrin, also known as Zyban, only antidepressant approved for treatment of smoking cessation. Varenicline, you probably know it as Chantix. And then there's the gum, lozenge, and patch, which are all you don't have to buy the brand name. You can buy them from Target. The over-the-counter are not paid for by insurance except for Medicaid, managed care in New York City. Some I've found actually do cover it. I've been surprised by a couple of people's insurance actually do cover these over-the-counter. It's unusual. You can call the Quit line and get 2 weeks worth of free medication, patch, or I think gum. So it's a way to get started on some free product. I find that people often have used these medications before. I mean, actually, this woman who doesn't want to quit before Passover, 75 and only quit once in her life, tried to quit once in her life. That's very unusual. Most people, you ever heard the Mark Twain quote where he said, "Oh, quitting is easy. I've done it 1,000 times." And so most smokers come to me having had a lot of experience with quitting. And they say to me, "Oh, the gum doesn't work, and the lozenge doesn't work, and the patch doesn't work." It's not that they don't necessarily work. So I do a detailed list. Well, how did you use the gum? Or what was it? So these products aren't used the way they are normally used in life. So you don't chew the nicotine gum the way you chew regular gum. You don't use a lozenge the way you use a sucking candy. And the patch has to be moved every single day to a new spot, or else you're going to get a horrible rash. So there are these funky things that, again, your primary care doctor doesn't bother telling you. Nobody reads the insert information. And so people use these drugs wrong. And so I always show this because this is the way you chew the gum. You chew it, it gets peppery, that's the nicotine being released. You park it between your teeth and your gum, so it gets absorbed in your buccal mucosa, in your gums, basically. And then the peppery taste goes away. You chew it again to release more nicotine. You park it again. Chew, park for 20 minutes. And if you don't do that, if you chew it like regular gum, or if you start to crunch on a lozenge and suck it instead of parking it, you're swallowing all the nicotine, and that leads to a very upset stomach. Hiccups, bad news. So I'm just making a point of this because if any of you want to go out and use this, it's my pet peeve that folks, and even when you tell people, it's hard to remember. Like if you're a gum chewer like I am, and then suddenly you're chewing something that you're not supposed to chew the way gum, it's tricky. But let me just see this. Okay, so I'm using more of the inhaler these days. It is a prescription. Not every insurance covers it, but a lot of them do these days. It's this big. You open it, you put a cartridge in, and you puff on it. It's not puffed like a cigarette. You puff it like people told me, like a cigar. I've never smoked a cigar, but because again, the nicotine's absorbed in the throat and the mouth. The reason why I tend to sort of use this in people who, if they don't want to use varenicline or for any reason, or but they smoke a lot, like heavily addicted smokers who are smoking 20 or more cigarettes a day, I will put them on the patch and the inhaler if they're willing to use the inhaler, because it gives them the hand-to-mouth ritual. The e-cigarette does that too, which is why smokers are running with their, running to the stores to buy them. Because that hand-to-mouth ritual is one of those behavioral dependence components that's very important to a smoker. So I like inhaler versus e-cigarette because I know how much nicotine my patient's getting. It's FDA approved, and I know it's totally safe. But I also am a doctor who wants people to quit. So I'm on your team when you're my patient. Like, if you're insisting that the e-cigarette is the only thing you will use to quit smoking, it's rare that you'd be in my office about that. You might just do that on your own. But I see people like that who've tried other things, and I'll go with it. But, oftentimes smokers complain about it. I don't get enough nicotine or whatever. It's not a cigarette. It doesn't deliver nicotine the same way. The safety profile is unclear, although there is no question it's safer than cigarettes. No question. The data came out of the UK, actually has it on their formulary, but the UK is much more progressive, amazingly, than us in the US. I was shocked by that, honestly, but we haven't been able to do studies on cessation with e-cigarettes in this country. There was a systematic review. It only included about 4 or 5 studies. There's some promise that it may be this reviews has suggested that it might be as equivalent to a patch or gum, a nicotine replacement therapy, but those studies have to be done. So we're on this parallel road, though, that's kind of weird. Like, we're trying to prove safety as we're trying to see if it helps people quit. Because smokers are saying to us, we hate the gum, the lozenge, and the patch. It's like, those things don't give us what we want, nicotine puffed. If we could come up with a safe e-cigarette that helps people quit, it's terrific. We just don't have the data yet so far. I could spend a whole hour talking about e-cigarettes, and I don't want to do that, obviously, today. I can answer some questions, too. I want to give us 5 minutes or so. This is sort of I call it Chinese menu or bottom line when I train docs, because docs are very busy and they're very confused by treating tobacco use. There's 7 medications. But if you look at, I'm not going to show you the slides I show the doctors when I train them that has kind of the several meta-analyses of these studies. But what it's come out is that when Chantix is used alone against the patch or the gum or whatever alone, Chantix wins. Chantix triples the chances of, and I'll get corrected by Karen here, chances of quitting versus placebo. When varenicline went up against bupropion, again, it beat bupropion alone. But if you look at the data closely, you'll find that if you combine a long-acting, meaning the patch, with a short-acting nicotine product like gum, lozenge, inhaler, you will get close to the varenicline outcome, like 2.8, odds ratio 2.8, meaning you're 2.8 times as likely to quit than someone who got a placebo, which is not the real drug. And similarly, this bupropion, if you add nicotine replacement therapy, it doesn't really matter what it is, you can up the quit rates there as well. My 2 favorites are these 2. If someone comes to me depressed and not on an antidepressant, and it seems like that might be the way to go, I would actually use Zyban. The problem with the bupropion is a lot of contraindications to it. But it's, safe. And let me just see. I don't remember what slides I put in here. So has anybody tried varenicline here? So it comes in a starter pack. It's a 1-month starter pack, very easy to use. You can smoke the first week. Frankly, there's some studies showing that you should maybe smoke for 2 weeks. You can, it's nice because people can smoke on it and they won't get too much nicotine. But I tell my smokers that, if at 1 week you're not quite ready to quit yet, it's okay. Just keep taking your Chantix. Chantix, maybe my hypothesis is that, Chantix came out ahead of those other drugs when those other ones were used alone. because it has an agonist and an antagonist effect. The agonist effect means it binds to the nicotine receptor the way that nicotine replacement therapy, nicotine in the patch and the gum do. It causes a release of dopamine, which is the happy neurotransmitter, makes you feel good. But it also works to block any more nicotine from being bound. So if you slip on smoke a cigarette when you're using the patch, you actually you'll feel that great feeling of like you got that cigarette. It does release, it does activate the reward pathway, the dopamine pathway. But if you smoke a cigarette on Chantix and it's working, varenicline, if it's working on you, not every drug doesn't work on every person, right? But I know when a patient's it's working in Chantix because they'll tell me, I slipped to smoke a cigarette and it was disgusting, so I didn't enjoy it. I put it out. I had never heard that before with any other medication, smoking cessation medication. So that's sort of the power of that medication. It seems to kind of really take down the cravings, doesn't make you enjoy cigarettes anymore. So I've had a lot of people quit on that. I've had people also quit on combination. 75% of people are underdosed. If you're smoking 15 or more cigarettes, you should be on a 21 milligram patch and on one of these short-actings every 2 hours. I kind of treat to target, which we do in blood pressure. And my target is withdrawal symptoms. If you're feeling antsy, I've had people on 3 patch gum inhaler before varenicline came out. There's not, my reading of the literature is that there's not great evidence on combining this yet with other, there have been a couple of studies, may cause more side effects, if you combine it with nicotine replacement therapy, binds to the same receptor. I don't have time to get into the potential side effects or anything like that here. This came up with a patient recently too. The FDA changed the labeling for NRT, nicotine replacement therapy products, so it's important. Safe to use more than one. Interestingly, they finally said, they acknowledge it's not dangerous really to use this with cigarettes. Now, do I want my patients smoking and using nicotine? No. But nobody knows how to titrate nicotine level better than a smoker. It's really almost impossible for a smoker to overdose on nicotine. It's not impossible for a kid to, but for an adult who's been smoking a long time, they know when they've had too much nicotine. And they'll stop. And, it's why when you see people coming outside every hour to have a break, they're titrating their nicotine level. And if you're a smoker, you understand what I'm talking about. So I don't worry about that. When someone comes to me and saying, I feel lightheaded or dizzy or palpitations, my first question to them is, how many cigarettes have you smoked today? If they're on the patch and the gum. So it's not because I'm giving them too much nicotine. It's because they're smoking too much on the nicotine. But it's not unsafe. So these are some of the resources. We have a quit line. I didn't want to overwhelm you with resources because they're just a lot. But our quit line's been around for a long time. They have that free starter kit that you can get from them. They also have a website with support. New York City has a Help Me Quit app. And the government, so smokefree.gov, if I had time I'd go online. Oh, there's a clock right there, actually. Has a lot going on their website. And I don't think I added the Become an X. BecomeAnex.com. It was developed by the Legacy Foundation and also has lots of great stuff on it, actually. So those are the 3. I would only go to smokefree.gov. I might go to our state website or Become an X. I think, though, seeing me once a week or once every other week, that you're dealing with this every single day, every single hour that you're awake. So having some support through text messaging, live chat, website, smoking apps is important. But there's thousands of smoking cessation apps out there. So stick to the ones I'm talking about because I have no idea what's going on with these other ones. And this is one of the times you can trust your government. I know the people who developed the sites. This is the National Cancer Institute. They're the good guys. And I really believe in their work. So again, call the quit line, or if you're someone who likes to not talk to people on the phone, but rather talk to them online, either go to their website or go to smokefree.gov, or as I said, becomeanx.com. I talked a little bit about it. These products have evolved from Enjoy's first came out in the market with one that looked like cigarettes and figured out that smokers actually don't want to be using a product that looks like cigarettes because they're trying to get off cigarettes. And it's interesting how the products have evolved to now be this crazy thing called Juul, which unfortunately I've been called by the community board in my neighborhood to be on a panel. Parents and teachers are in uproar on the Upper East Side because this product is just kind of taken over in the schools. It looks like a flash drive, lots of nice flavors. You know, there's this dilemma because smokers like the flavors because it takes them off the... They've moved, actually, you'll see a smoker will start with a nicotine flavor, and then they move to the gum and, well, I don't know what they move to, but some kind of other flavor because they don't want to really be prompted to smoke. But for kids, this is bad because this is the way the cigarette companies attracted kids to smoke. They made flavored cigarettes. We were, I think, the first city to actually outlaw flavored cigarettes. And I think that's where this is going. This is, again, a dilemma. For someone who cares about helping people quit, I'm afraid that the government's going to overregulate e-cigarettes and, so that they're not available anymore. Like, if they do that and cigarettes are still available, that's insane, okay? Because it's the cigarettes, it's the combustible tobacco that is really the enemy. And, e-cigarettes, again, we're not totally sure, but there's no question that if the entire population of smokers moved to e-cigarettes tomorrow, we'd have much fewer people dying of cardiovascular disease and lung cancer and other cancers. At the same time, my first go-to are the drugs I showed you before, the FDA-approved medications. That's what I ask my patients to start with. And in this city, and this is the other thing, my soapbox with this prevention thing, is we know how to get kids to stop smoking. Meaning we know how to get kids to not to smoke cigarettes. That means we know how to keep them from smoking e-cigarettes. It's the same policies. So one of them was this past, you're not allowed to smoke. In the same place you're not allowed to smoke cigarettes in New York City, you're not allowed to smoke e-cigarettes. They just started taxing the liquid a little bit. There's going to be more and more regulation around here. We're always kind of a leader here in New York City with those kinds of policies. Hookah is also bad. That's all I have time to really say about it, but don't use hookah. It's also growing among young people in college. We just did a survey of the CUNY students. It was unbelievable to me. 2,500 City University, New York students, 25% are using hookah. Huge. It's more than smoking a cigarette. People think it's safe because you're breathing in through water. I don't know if I believe this, but this is the CDC, so I guess we're supposed to believe them. But 1 hour of hookah smoke is equivalent to inhaling for 200 cigarettes. It's pretty dramatic. So this is the smokefree.gov website. See, it's kind of nice. I like about it? It's a little easier to navigate, actually, than the Become an X website. But it has everything on it. Websites, you have to click around, sort of figure out what's what. But there's a lot going on in this website that's really good. So again, I really encourage you, if you're trying to quit, to do that.